your slides for you. So I'm going to start sharing my screen, and then just let me know when you'd like me to advance the slides. How does that sound like a good partnership?
Sounds like a great plan. Thanks so much.
Okay, great. So I am going to start that. And can you guys see the slides?
I can.
Great. Okay, so Dana, Mott, Bronson, welcome. Take it away.
Thank you so much. And if you want to go ahead and advance to the next slide, and we'll start from there. But first of all, I want to say thank you so much for having me. I have been looking forward to it, and hope that we can have a great conversation this evening. Feel free to stop me at any point, ask me questions. If I don't know, I will try to get back to you with an answer. I never have shame in saying I don't know something, but always like an opportunity to follow up. Also, full disclosure, I hope that I won't be getting interrupted by a frantic 16, almost 17-year-old, but I don't lock my door, and my daughter does have a tendency to walk in. It's been a big week. She has her driving test tomorrow for her license, and she turned 17 on Saturday. So it's a little bit of an exciting time outside of the election in my house. So hopefully we won't have any disruptions. But as you can see here, really looking forward to just spending some time with you this evening, talking about a couple of things. So maybe level setting a little bit about, as Tom mentioned, the HCSC Federal Government Relations Policy Office, which is in DC, and we are at 1001 Pennsylvania. So I think probably FBI is to the left of us, and to diagonal across the street is the Trump Hotel. So we get a lot of activity, a lot of people coming by to see it, sometimes protesters. So it's an interesting location, but want to talk to you about what we do, and particularly what we're focused on now. I bet you have some thoughts on what that might be. Certainly talk about internally how our office kind of engages with the business and with leadership from a public policy analysis, development, and socialization perspective. I think that that's really important for us as an organization, and any organization in the managed care space. And then wrap up and talk about what we are focused on now. So the kind of healthcare, federal, legislative, and regulatory landscape. So we can move to the next slide. Thank you so much for driving. I appreciate this so much.
Well, I haven't passed the test yet. There we go.
You have passed, it's fine. So starting with the Federal Government Relations Office, who are we? So we were established, so HCSC basically established our office in DC following the passage of the ACA. As you can imagine, a big need for advocacy in DC, where everything was happening as ACA implementation got underway. The office now includes 10 staff, and we really do cover a range of functions. So public policy, certainly anywhere in kind of federal programs or the private market space, Medicare, Medicaid, Medicare, Medicaid dual eligibles, CHIP, exchanges. And then we also have someone who is in our office virtually, but really is kind of our state liaison. And so certainly state issues and our coordination there is staffed in our office as well. Lobbying, of course, we are the DC office, so lobbying from a congressional perspective, the administration, NAIC, the National Association of Insurance Commissioners. We have expertise in the office in relationship management. So beyond kind of the regulators and members of Congress, there's also external organizations that we maintain relationships with, generally at the national level. So I have here clinical organizations, but also I think about the standard setters in CQA, in QF, for example, and other trade associations we kind of work closely with and have relationship management responsibilities there. And then HCSC's Political Action Committee also is run out of our DC office as well. None of us, of course, are there right now. We're all remote and working from home in various locations in the DC metropolitan area. But our staff, as Tom said too, we have a broad range of past professional experience. So certainly congressional experience, administration experience, so some previously HHS, CMS, the Government Accountability Office, GAO. We even have NAIC staff experience, about half of us also have trade association experience. So between the Blue Cross Blue Shield Association, BCBSA, and AHIP, we've all done some time there as well. And then of course, individual companies, other insurers, PBM, so the pharmacy benefit management managers, some from either, their trade, PCMA, or PBMs specifically, and then consulting firms. So this is really just to show that we have an array of experience and hopefully are doing a good job representing and advocating for HCSC at the federal level. So we can advance to the next slide. So that was who we are. And so what do? We are, I think, responsible for a broad range of issues. We work really closely with the business. We work really closely with the legal division, but we are immediately responsible for public policy analysis, development, and socialization. So that, I think, looks like a lot of different things, and I'll talk a little bit about it, but we also are responsible for the policy, government relations, strategy, and advocacy. So kind of once we go through that public policy analysis, development, and socialization, so making sure everyone is aware of the public policy analysis and development, we are then responsible for executing on what the strategy for advocacy looks like around the policy that we come up with, or either the policies that we are commenting on and helping to shape at the federal level. As I mentioned a little bit, we manage the relationships with federal regulators, administration officials, members of Congress, and our trade associations. So we are the ones that are on a daily basis, either interfacing via phone calls, mostly now, of course, everything's virtual, or in person with the regulators, with the members of Congress. And we are representing HCSC, and that includes all 5 plans with our trade associations, and working closely with the trade associations to make sure that their advocacy efforts align closely and reflect the input of and the priorities of HCSC. We also are responsible for the direct comment development process. So anything that you see that comes from any of the federal agencies, any draft legislation, for example, or even legislation that has been introduced from Congress, we are the ones that are responsible for working directly with the business to develop any comments or feedback. So that gets to be a robust process. We'll walk through that a little bit too on one of the next slides. And then I think this is the most important, is that we coordinate closely with our internal business and operational teams. One of the things that really excited me about going from a trade association and coming to a plan was being able to go deeper on the operational issues, because not that I live in that space, but I think understanding those issues in more detail allows me and my colleagues in the DC office to be better advocates. So I'm sure some of you might have even have interacted before with some of my colleagues, but we appreciate the time that the business and the operational teams spend with us to help make us a little bit smarter, so that we can do the best work possible in advocating at the congressional level, the federal regulatory level. So I'll probably say to some of you, thank you on behalf of my colleagues, who I'm sure that some of you may have interacted with. Any questions before I go to the next slide? Okay, please, we can move to the next slide. So this is really the public policy analysis, development, and socialization process that we engage in internally at HCSC to kind of push policy through, whether it be, if you start here with the policy vehicle, whether it's federal legislation, draft from Congress where we have an opportunity to weigh in, or legislation that has been introduced, but we are trying to lobby on it, and so want to make sure that we have a little bit more understanding of how it might impact the business and what our positioning would be, whether it is regulation, so rulemaking coming from the federal government, or sub-regulatory guidance coming from the federal government, so a proposed rule or draft guidance, or whether it's a proactive initiative where we've worked with the business, we have identified a policy hole or operational hole where we need different, better, more robust guidance, or we need a new policy. So we proactively identify an effort and work to develop it from scratch and move that through our internal process so that we could have a strategy and an advocacy approach. So that's kind of identifying the different buckets. And then we as the government relations team will kind of take that bucket. So that's kind of identifying the issue, whether it be the legislation, regulation, guidance, something proactive, and we assess the potential impact on the organization. And I think that is where having that almost being embedded, if you will, with the business is really important, because we are doing that initial assessment on what does this mean for HCSC, or what does this mean specifically for one of our 5 companies. And then once we've done that initial assessment in terms of impact, we figure out what the next step is going to be. Do we think that we need a new policy? Do we think we need to have a revised policy? Is this just an instance where we want to be giving feedback to the federal government to shape, or Congress to shape, something draft or proposed that they have issued? So it's our initial step is kind of tracking these issues here. The biggest next step is internal stakeholder engagement. Again, I can't stress enough how important it is for us to be able to have access to and work directly with the experts in the business, the subject matter experts. I don't think at all that you can trade off or replace that expertise. So we have a range of, I think, approaches that we employ to work with internal stakeholders. It could be something small where we really are having a one-on-one conversation, but generally these are broader calls where it varies from a handful of people to, I was just on a call right before I joined you with about 25 people going over proposed Medicare Advantage payment rates for 2022. So it could be a very small group, one-on-one, to kind of a bigger audience where we need a range of stakeholders and expertise to come together. But we work to evaluate and validate that the concerns or the issues or the feedback that we've initially flagged is right, that we haven't gotten it wrong. There often at this point is additional analysis from a business impact perspective. So often finance or the actuaries will do a deeper dive on dollar and financial impacts. And then based on kind of those discussions and then further analysis, we will work with these stakeholder groups to develop recommendations on what our position should be and ways that we could advocate for those positions, both making sure that our trade associations are bought in and are moving in that direction, but then also our broader kind of advocacy strategy with whether it's Congress, whether it's the federal government. The next step, also very important, is working with senior leadership. So once we have those kind of packets or we have our recommendations packaged, we then move on to work with senior leadership to make sure that that positioning aligns with their perspectives and that we are in the right place and that they give us the seal of approval. If it's something that's a big game changer policy, kind of the senior group of stakeholders is a little bit bigger. If it's something one-on-one, like for example, in my case, I work and lead our Medicare policy and GR efforts. It might just be with the Medicare team and leadership, but that does depend on whether something is kind of cross-functional and impacts multiple lines of business, or if it just impacts one line of business, for example. And then it comes back to us, balls in our court. We take those recommendations that we've worked with everybody to develop, or the comments that we've worked with everyone to vet and develop, and we move those on in the process. So again, getting our associations to align with our positioning, and then moving forward with advocacy at the either federal government level, so CMS, HHS, the congressional level, lobbying Congress, and sometimes that includes other stakeholders if we're trying to build coalitions and coalesce around issues of mutual concern where we can find some alignment. But that's at a high level, kind of what our internal process looks like. It varies depending on, sometimes we have a lot of regulatory activity, we have a lot of legislative activity, and so it gets to be pretty intense. And then other times it does die down a little bit. And we actually can use those opportunities to, again, build up our operational acumen and awareness. But any questions there? I'll pause just to see if you have any questions or thoughts. And if not, I probably think that the things that I'll be talking about after after this, now that you know who we are, where we are, what we do, how we function, to me the exciting part is what are we doing right now? And I think that we're probably focused on the same things that you and the rest of America are focused on, and that is certainly change in administration. What does it mean for healthcare? You know, big issues. So if we don't have any comments or questions on our kind of internal policy development and socialization process, we can advance to the next slide.
Here we go.
Get to maybe some more exciting things. So it seems really odd to just have 3 bullets here on what we're focusing on currently, because it is broader than this. But the things that I think are probably things that you'll be most interested in, and that you all are probably to some extent focused on, if not professionally, maybe even just personally as well, but certainly final regulatory actions from the current administration, anticipated directions from the incoming administration, and then anticipated congressional directions. And so this will, I'll start kind of with the coming weeks in the lame duck, if you will, Congress, and then also the last couple of weeks of this current administration, and then talk a little bit more longer term. But if we go to the next slide, we'll talk about the kind of final regulatory actions from the current administration. So I don't know how much of you, how many of you have been or were focused on this, but we really have seen increased regulatory activity from the current administration over the last several weeks and months. I'll say, you know, somewhere from late summer right up to the election, we were seeing unprecedented levels of activity, particularly focused in the healthcare space. And I think there were a number of drivers for why. We certainly, from executive orders, I think probably saw, from a healthcare perspective anyway, and Medicare specifically for me, more executive orders in that short period of time than we certainly are used to as we're going up or heading up and heading into an election, a general election. From a rulemaking perspective, we saw a lot of proposed rules introduced, dropped, and some final rulemaking coming out as well. And then also announcements around demonstrations and payment models. So it was a lot of activity when typically the rule of thumb during an election year, a general election year, a presidential election year, is don't rock the boat. So don't issue anything. You don't want to upset anyone. And that was not the approach that was taken. I think some of it certainly was to be able to complement some of the activity on the campaign trail to fulfill promises. But whatever the driver, we saw a lot of activity. And then immediately after the election, we saw a lot of activity as well. So I know we're still kind of in that immediately after phase, but we are continuing to see regulations, specifically rulemaking, come out from the current administration. And we are anticipating that between now and the end of the year, and maybe even mid-January, we will continue to see more. So for example, as you can imagine, we believe that it's their last opportunity, the current administration, to kind of put their mark from a healthcare perspective down. From my perspective, focusing on Medicare, they have been very focused on increasing regulatory activity and rulemaking over the last 4 years in the Medicare space. And I think that they are working to push some final rules out the door again to execute on those priorities. Right now, there are about 15 proposed rules that are pending for review and release that are healthcare related. So from HHS, they're pending with the Office of Management and Budget. So sitting over there, we're watching them daily. We're expecting for at least some of them to come out. For example, we know that we are anticipating kind of annual rulemaking for 2022 for Medicare Advantage and Medicare Part D. So the policy and technical changes that we see on an annual basis, that should be imminent. We should see that soon. The big Medicare fee-for-service payment rules are expected, specifically the physician fee schedule for 2021 should be out soon. Will be interesting because that is effective January 1, 2021. And so we will have, as an industry, probably certainly less than 60 days to implement those requirements. It normally is required, at least a 60-day implementation window. So the final rule has to come out 60 days before it is effective. But that was waived because of COVID-19. Understandably, the administration didn't have an opportunity or time to get the final out before that 60-day window because of the competing resources needed to respond to COVID-19. But other fee-for-service rules also pending, HIPAA privacy rulemaking, we are expecting, it's a possibility that we will see it in the coming weeks, and also final rules around the physician self-referral requirements, so the Stark and anti-kickback requirements. And all of these are, generally in the Medicare space. And so there are other HHS proposed rules or final rules that are pending as well. We also think, even though these aren't pending at OMB, that we might even see other priorities addressed in the coming weeks from this administration. So many of you may have heard that they've been quite focused on getting out another round of rulemaking on interoperability. So it's interoperability 2.0 with a large focus on prior authorization. So portability issues and other issues of changing, proposing new potentially prior authorization requirements that will have impacts for the Medicare program, but also more broadly. Beyond Medicare. And I think that for kind of a lame duck presidency, if you will, this is not typical. So we're bracing ourselves and every day obsessing over the Federal Register, which is a very wonky thing to say, but that is how I start my day every morning, looking at the Federal Register and seeing what they're going to give us. I also end my day that way. So I think I might be making you all feel sorry for me. Maybe I need to find something else to do with starting and ending my day. But the point is, we're anticipating a lot of regulatory activity, certainly more than we would normally anticipate when we are seeing a transition of an administration. Any questions there before we talk about what we might expect to see from the incoming administration? All right, and we can move to the next slide. So I think from, an incoming administration, I want to say, I think for both administration and for Congress, which I know we'll talk about next, everything that's going to be happening soon is going to be through the lens of COVID and the public health emergency, which I don't think is a surprise to anyone, but I think it's important to level set and say that. But for the incoming administration, I think that there are certainly regulatory actions and priorities that will be consistent with this current administration. So some overlap there, but I think that there also will be some key differences, also no surprise. Starting, of course, with COVID-19, I think we are probably likely to see what people would characterize as a more robust federal, kind of coordinated federal effort around responding to the COVID-19 pandemic. I think that you probably will see more empowerment potentially of maybe what you would think of as the scientific agencies in the COVID-19 response. So NIH, CDC, FDA even potentially. I think you'll probably see a push, and this again is COVID-19 specific, to have more control over PPE and how that gets disseminated and what that focus is. And then I think kind of working with Congress, you'll see a push for another kind of legislative package, which we'll talk about as well, that might seek funding for public health infrastructure, potentially providers. And I think no surprise. I don't think we would be surprised at all for the public health emergency to continue to be extended, potentially through the end of 2021 at least. That has been, of course, extended by the current administration. It's every 90 days, if I'm remembering correctly. And I think that the PHE expires right around the same time as the inauguration. So I think from a COVID perspective, those are the things that we would immediately expect to see or start to expect to see from the incoming administration. For Medicare, Medicaid, and the ACA, I think for Medicare, we might see things slow down more than speed up because there's been so much activity from this current administration. I think we'll continue to see the drive toward value-based care. So moving from, fee for value to fee for service to fee for value. I think that's going to continue. I think we'll also continue to see focus potentially, again, this would be Medicare, on drug pricing affordability. So any activities or actions that they can move from a federal regulatory perspective, we would expect to see that to continue to be a focus. So reducing beneficiaries out-of-pocket costs. From a Part D perspective, I think we potentially also would expect to see maybe a continued focus. This would be more in the Part B space, but if you remember, the current administration through an executive order announced that, and then an advance notice of proposed rulemaking about a year and a half ago, an international pricing index model for Part B, which has kind of morphed now into most favored nation, is maybe that's how you've heard it, but basically it is, requiring and putting in place an infrastructure where, Medicare would not pay more for a drug from pharmaceutical manufacturers than the cost of a drug in a similarly situated country. So that is the current administration a proposal there, but we think it is part of kind of the platform to drive drug cost affordability in Medicare of the incoming administration. So it's likely that we could see that. But we also think there's a possibility that we could see rulemaking. I failed to mention this on the prior slide, that we could potentially see rulemaking from the current administration on this issue. So that's an area where I think that they definitely have some overlap. But I don't think we'll see a lot, in the first 100 days, for example, from a Medicare perspective with the incoming administration. But I think there's some potential for some things. I'll talk more on the congressional side because I think that the incoming administration did have some ideas on the Medicare program that would require some legislative changes. I think for Medicaid, we would probably see a continued focus on maybe rolling back some of the policies or priorities that have been acted on by the current administration. So maybe loosening up some of the eligibility restrictions, so kind of moving in the other direction. I think also from a social determinants of health perspective, giving some more flexibility to states and MCOs, Medicaid MCOs, to cover those type of benefits for a vulnerable population. I think other areas, MFAR, which I'm not exactly the expert on, but certainly I think issues in the Medicaid space that have not been so popular for some who are very supportive of the program that we have seen occur under the current administration. The incoming administration might look to, for example, roll some of those things back. I think from an ACA perspective, that's a loaded, I think, issue. I am no expert on kind of the exchanges or ACA, but we know we had the oral arguments, of course, earlier this week at the Supreme Court on Texas versus California. And I think those were really interesting. I'm not normally one that's plugged into the SCOTUS conversations or the Supreme Court discussions or arguments, but that is certainly one that you all know has gotten a lot of attention recently. So I think maybe what happens on the ACA is going to be dictated a lot, and this of course is on the regulatory side, by what happens there, and then ultimately what Congress may or may not be able to do. But at a minimum, administratively, I think we would expect to see, like, marketing, or I should say education and outreach around the exchanges to come back online and be a little bit more robust, not kind of rolling back, the walking back of some of those activities under the current administration. I think that we would see, reversals of policies around short-term limited duration plans, association health plans, and things like that. So certainly probably a space where you would see some of the current administration policies rolled back. And I think that from a drug pricing affordability perspective, I talked a little bit about that from the Medicare perspective. I think that we would continue to see just a broad commitment to drug pricing and making drug prices affordable broadly for beneficiaries, for the healthcare system, certainly from a federal program perspective. There will be probably some differences in how they go about doing that, but I think that's going to continue to be a priority for the incoming administration. And then I think from a telehealth, digital health perspective, I would the genie is out of the bottle with telehealth. I would expect to continue to see the incoming administration, certainly through the PHE, support the expanded flexibilities around telehealth. And I think that we'll probably see some of that potentially move beyond the PHE as well. And then from a digital health perspective, this is really, I think, interoperability, for example. I think that will continue to be a focus as well, whether we see some of the kind of compliance dates or the timeline for implementation of the first interoperability rule adjusted. I think that's something that could be likely, but I think that that's a possibility, but I'm not sure that we would see any major changes to the kind of existing rule. That's my speculations. And I should have said at the outset of all of this that the nature of what we do is point in time. And so something could happen where we wake up tomorrow and everything that I just said to you is not true or false or inaccurate. And so I should have put that disclaimer and disclosure out there in the beginning. So any questions just around incoming administration, what we likely would see them focusing on?
I have a question.
Sure.
So I'm Katie Root. I'm an internist, primary care. And what do you see as far as telehealth reimbursements? I know temporarily through the COVID era, there has been, kind of a boost in that. It's been treated more like just a regular office visit. I know that, obviously the overhead is different with a telehealth visit and all of that, but, the time spent from a physician's perspective is the same. So do you see that changing much in the future?
I think it'll be something that's up for debate. The issue around payment parity is real. And I think there have been opportunities, at least initially, to start weighing in, at least from a regulatory perspective. So again, in the physician fee schedule, there were a lot of proposals there, certainly linked to the PHE. And that is where we initially, I think, saw some moves from CMS to keep some of those policies around on a more permanent basis. So I don't know where it's going to end up, but I think it is a very real piece of the conversation, and it's going to continue to be, I think, a key driver of both, I think, on the congressional side, but certainly on the regulatory side as well, where this conversation goes. The current administration, as you know, has been working very closely with the provider community. So not just from a telehealth perspective, but more broadly. And I know that that's one of the issues that has been on the table. I would expect it to be a continued focus going forward, but just not exactly sure where it will end up.
Okay, thank you.
A good question, though. Sure.
Great question. Anyone else question? Because I had one, Dana.
Yeah.
But...
I had a question as well, Dana. Thank you so much. This is such an interesting topic to me. So I previously worked with the dual population as well. And I heard a great New York Times piece on the incoming administration's plan to almost use COVID, the pandemic, as an accelerator for some of these social policies around these populations, Medicare and Medicaid. So for the dual population specifically, are there any of those social determinant to care issues that you were excited about them gaining access to?
Yeah. So this is, stop me if I talk too much, but thank you for asking the question. I actually haven't read the New York Times article, so maybe I'll go out and Google to see if I can find it. But first of all, I think issues around enhanced and expanded opportunity to address social determinants of health. I did mention that on the Medicaid side. It also is a very real issue on the Medicare side as well, to the extent that, this is for, or benefits are targeted for serving duals. So I don't know exactly what their specific thoughts are, what policies or what benefit changes, for example, they're putting on the table. But I think that COVID is a real opportunity. And I've actually been able to attend a couple of conference sessions virtually recently that are focused on that very same thing. Social isolation, I think, is also something in the Medicare, Medicaid dual eligible population that is gaining a lot of traction. So even though it's not a specific benefit focus, I think the issue itself, which is really critical, right, in the senior population, frail elderly specifically. So I think that COVID is going to, it has provided a lens for that issue specifically being addressed. I think even pre-COVID, but certainly driven by COVID, the kind of social supports that we see covered from a Medicaid perspective more than we do from Medicare. There has been a constant drumbeat moving in that direction. So I think that we will continue to see that. I would be surprised if the incoming administration took a different approach than the current administration. And a lot of this also is driven by Congress, right? So it's not just the incoming administration or the current administration. It's a bipartisan issue where Congress in the last couple of years have made this a focus. And so I think it's absolutely right that COVID is going to just kind of propel the issue forward in terms of awareness and support. But I also think there was already a pretty strong drumbeat for focusing better and serving the population. What I'm really excited about also is what we do with this population going forward, right? We have the Medicare, Medicaid integration, the capitated financial alignment demonstration to test better integrating and aligning, including from a financing perspective, Medicare and Medicaid, two completely different programs coming together to serve this population. So I think it's only a matter of time on the congressional side, and hopefully with the support of this administration, where we really have to think about what do we do on a more permanent basis to better serve the population? Is it a, Medicare Part E, some people say, but I think that the specific issue you're talking about, better serving and focusing on issues specific to the population from a benefit perspective, from a programmatic perspective, is real, and I think will gain traction. But the bigger policy issue of what type of program do we have in place going forward to effectively serve this population? I think it's something that we're probably soon going to be able to be talking about legislatively. So yeah. I'll stop before I ramble on more.
No, Dana,
yeah,
it's
very
excellent.
exciting. Yeah, very exciting stuff. Thank you.
We need about 2 hours with you. I know you have one more slide, and we definitely want to get to that. But could you give us just maybe the 30,000 feet on the Texas versus California, the Supreme Court discussion that occurred on the 10th, and just what's your take on that, just very quickly, and then we've got about 5 more minutes. 5 to 6 or 7 minutes for you, and then we'll probably need to change into the next section.
Sure. Again, no expert here, but I feel like you all are probably listening to the very same things that I'm listening to. But of course, the issue was really probably one of the, at least people who have legal backgrounds. I am not an attorney. I don't even play one on TV, but the issue of the mandate and whether the mandate itself, of course, was constitutional, was before the Supreme Court. And I think there were a lot of surprises. I think going in, there was probably some strong clarity that you had at least 3 justices that would be on the side of where we as insurers would hope that they would land, but there was some very strong support, I should say, at least some markers put down in a way that, again, not always following the Supreme Court oral arguments. It definitely sounds like there were some surprises in how strong, in terms of putting markers down and the questioning around standing, for example, coming from the Chief Justice and then certainly Justice Kavanaugh. So I think it gave a lot of people confidence that when we ultimately do see a decision come down, which we would expect at some point next year. So, first half of the year, for example. I've heard some kind of timeframes differ, but I think that it certainly sounds like from everyone that I've talked to in the 3 different webinars that I've participated in the last 2 days, that people feel more comfortable, people who are supportive of the ACA feel more comfortable about the outcome of the oral arguments than they did heading into the oral arguments. So that's my really high level kind of takeaway, but it seems like the general sentiment for supporters of the ACA was sleeping a lot easier, breathing a lot easier post oral arguments than they were before.
Great. Oh, thank you.
Does that
That's
help?
helpful. Yes, it does. Ready for the next slide?
Yeah, and I think this aligns a lot with kind of the incoming administration.
Yeah.
All eyes are on Georgia, as you know. My mother lives there, so it's interesting talking to her every day. But kind of the balance of power in the Senate, clearly under Republican control right now, GOP control, is kind of hanging in the balance with these 2 Senate races in Georgia that have gone to a recount. A runoff. And so the runoff is January 5th. Depending on where that shakes out, we could see probably, I think a lot of people believe that the GOP will maintain control, but certainly depending on the outcome and what the Senate looks like and the makeup of the Senate will influence what the incoming administration will be able to do legislatively, and also the issues that are here. I think from a COVID-19 perspective, we would, there's potentially an opportunity in lame duck. So between now and the end of the year, even potentially for there to be a legislative package. So going back to the negotiating table between the House, Senate, ultimately, something still has to go to the president to be signed, but I think there is an opportunity potentially for us to see another, so I think 4th, I've lost count at this point, COVID-19 package that really would be focused on economic relief for individuals, maybe high hit industries and so forth. So some potential in the coming weeks. The health extenders continuing resolution, if you remember, potentially if you were following it, there are some federal, so Medicare provisions, Medicaid as well, that are up for reauthorization or reappropriation, so they have to be funded. They have a short-term funding that goes through December 11th. Those are the healthcare extenders really for Medicare. It's like SHIP and beneficiary counseling funding for that to occur under Medicare. Also, some of the quality measurement development, I believe it's in QF. So those type of efforts have to be funded, and their funding goes through the December 11th, and just government funding in general. So we expect that will happen between now and December 11th to keep that going. We think there's opportunity for disparities and social determinants of health to be a priority for this incoming Congress, particularly for Medicare, for Medicaid, excuse me. ACA, I think we've talked a little bit about that. Expect that there could be an opportunity certainly for improvements, fixes to the ACA. I think that also depends on what we see, certainly from a Supreme Court perspective, but also where the Senate ends up. Drug pricing affordability, that this is a bipartisan issue. I think we do expect to see that there will be some action around drug pricing in areas where the House and the Senate have agreement. And I think that is regardless of if GOP maintains control of the Senate or not. So for example, Part D, I think we'd see moves to establish out-of-pocket maximums for Part D enrollees. No out-of-pocket max now for Part D, there is for MA. And then I think telehealth, some of the issues we already talked about, will be real and alive for Congress. One I don't have on here, and I don't know how I missed it, is surprise billing, because I think that's a bipartisan issue as well, and we should expect to see some activity likely from Congress on that also. So I feel like I'm probably missing something in my effort to not drag on, but happy to take any questions.
Yeah, this has been absolutely fabulous. This has been so good. Thank you so much. I'm going to drop the screen and just see if there's any one or two last questions for Dana before we give her the time to go read the Federal Register. Isn't that what you're going to do right now, Dana?
I'm so boring.
You said you're going to end your day. And then remember, the font on that was like about a 2 pica, so I don't even know how you can see it. But
I like to read the pre-publication, but you're right.
Okay. Any last questions for Dana before we turn the change the chapter?
Kind of a simplistic question. You said that policies could change or be thrown out with the incoming administration. Is there a rule of thumb, like as far as like a timeline for any changes to policies or exchanges to policies? Is there like a general rule, or is it all subjective based on the policy itself?
There's a congressional opportunity, excuse me for the noise, under the Congressional Review Act, and I should have this committed to memory, and I don't. But so Congress can take action as well, but the incoming administration, I want to say that, and when you say, is there a timing rule of thumb, do you mean from a look back perspective, or do you mean a window by which the incoming administration would have to take action on anything established prior?
The window to take action.
Yep. And I don't remember that from the top of my head either, but there is, I do believe that there is a window. If I can follow up with you directly, I'm happy to do it. I think I have everyone's email.
You know, you should. You will. I believe
I can either send it to you because this is knowable, and if you want to share it. But there are definitely parameters. I just don't remember what they are, and I definitely think that they will be leveraged.
Cool.
Yeah,
yes, looking forward to it.
All right.
Sure. Thank you for asking. Okay.
Well,
thank you
Dana,
so much.
we want to thank you, and some of the students are chatting and saying, please say thank you. This has been so enjoyable for everyone. And I really appreciate you taking your time out. I mean, you had a long day. It's 8 o'clock in DC. And so we appreciate you taking this time and being with us tonight.
Thank you for having me.
Great.
I appreciate it. You all have a great evening.
Take care. Thanks
Good
so
luck.
much. All right,
Bye.
great. Excellent. All right, well, that was really great. I really, really hope you guys all enjoyed that. And, you know, a lot of the things she was talking about, you know, it's just complex topics, and I'm sure you've heard terms you've used during the course and which in your readings and the materials. So hopefully you were able to track on what she was saying. What we want to do for the last, we've got about 10 minutes left, is this is our last time before the final projects are going to be presented. And I posted today in Moodle a document. I put it into the announcements, and for some reason it triggered all of these people not being able to get at it, and emails coming to me that you have to be authorized to get in. And IT said it has to do something, maybe if you're coming in through a non-UT or whatever. I reposted it into as a link. It's actually a PDF document you can download in the message, or you can go down. Modules 13 through 16 are now open. You can go into the modules themselves and you can get the link. So if you can't get it, just send an email and I'll flip it to you immediately. But basically what I do is I thought we could, Kate and I thought we could just take a few minutes and go through the document with you folks, see if there's any questions. And so I'm going to go back into a screen share, and then we'll walk you guys through through the document. Let me get out of here. Let me know if you guys can see the screen. Can you guys see the screen and the document?
Yes.
Yep. Okay, great. Get rid of some of that crap that's behind here. So we're not all distracted here. All right, great. So this document right here, you can download it either, get in the announcements. It's also in 15 and 16. But basically what we will do for the last two modules, you know, you have module 13, which opens up on Monday, and then module 14, which is Thanksgiving. So all you have to do for module 14 is eat turkey. And so hopefully that's a nice break for y'all. And then module 15, that will be December 3rd. We will meet together as a group. And what we'll do is that Kate and I will both facilitate two separate groups on both on Thursday night module 15, Thursday night module 16. And so all of you elected to do your presentation either in module 15 or module 16th or on December 3rd or December 10th. And so those dates are all baked into the process, but you'll be split out, and you'll be split out based on this grid that's you can see on the screen. And so Kate will take half the class and go into a Zoom meeting room, and then I will meet with the other half. And basically, if you signed up to do your presentation on the 15th, Katie, Root right there, Wendy, et cetera, right down the line, you guys are on deck for the 15th with Kate. And then these folks here who are going to do it on, who are listed below, are going to be in the audience. And then what will happen is that we'll just, on the following week, we'll just repeat the process. So with different presenters. So does that make sense to everybody when you're doing your presentation? You guys are probably on pause. If it's good, I just want to see your faces or something. Thumbs up, Katie, you're good? Yeah, so it's real simple. So if you were going to do it, all you need to worry about, I'll make sure you get into the right rooms. If you're ready, if you're doing your presentation on the 15th module and you're with Kate, you'll go into one room. And if you're with me, you'll go into another room. And I think it'll be pretty easy peasy.
So is not everyone in an audience for like, because I don't see myself in an audience. Are only some people in the audience?
Where are you at, Liz?
I'm in group A.
Yeah, right, yes.
Oh, I see. So, and I'm in the audience for module 16 for that. I got it. Okay, never mind. Sorry.
Yeah, no, look at that. Let me tell you what, you guys should send me, you know, a gift card or something, because this, for me to get my brain around this for some reason, I just couldn't, and I didn't want to communicate it and screw it up. And then everybody emailing me, and I said, Kate, please look at this to make sure it makes sense. So it's complex stuff. So if we screwed it up, we still got like a bunch of weeks to get it straight. But the goal is have two clusters of students. Half the students will present one night. Because see, before we we're going to try and do like, you know, 20 presentations, you know, in each night. It's just too much. And you guys have 5 minutes, but you know, 5 minutes turns into 6 minutes, and then you'll start, you know, elaborating on something. Someone will have a question, and we'll have some discussion. We don't want to be that rushed. Make sense?
Got it.
Good question.
I have a question.
Oh,
go ahead, Katie. I can ask.
Sorry.
It for you.
Are we supposed to share our screen and just use our own PowerPoint, or are we sending the PowerPoints to you first?
Why don't you guys, what we'll do is I will give everybody the capability to share the screen. And so I'll give you guys, because I think it'd be too much drama for me to try to organize everybody's deck, which only should be a few slides. So I think we'll just, everybody will have the option to share the screens. That's great. Great question, Katie. Shalene, did you have a question?
Yes, Dr. Marian. So when I look at myself, I'm in module 15, Shalini. I'll be presenting on which date? Will it be the first presentation?
Yeah, you had requested to present on the 15th.
Okay.
So you are in group B with me. And I don't know if you can see right there, you had asked for the 15th. So
Yes.
Shalini, right here, bam, module 15, you're going to be presenting. Okay.
Okay. And when will I actually, where am I for module 16 to be?
You will stay with me in group B. You'll always be in group B.
Okay.
And on the 3rd you'll present, and then on the 10th you'll be able to just breathe deeply because you signed up for the first one.
Thank you, Doctor.
Yeah. So, and hey, Jerome, are you still with us? I know I saw you join. Are you on? Are you still? I wanted to make sure you saw the note that I sent to you. I don't know if I can see your name. You're out there. I don't know if you're still with us or not, if you jump, but yeah, Drone, you're still, I see you're out there. I want to make sure you check. I think I sent you a note. So make sure you take a peek at that. So what are the questions?
When is the paper due?
I'm sorry?
When is the paper due?
That's a great question. If you look in module 16, and it'll show the paper is due by, the semester ends Friday, December 11th at 5 p.m. So all documents need to be submitted by that time period. And the grades, I think, are due early the following week. So you can submit, if you present on the 3rd, you can submit everything on the 3rd. I opened it up. I opened the module up. So if you want to submit early, you can submit anytime. I think it's opened up November 15th or something like that. You can submit right up to December 11th. And then, yeah.
I'm sorry, I had a question. On the references, is there a certain number you guys are looking for in the paper? Do we need like 5 references, 9, or?
Kate, I'm gonna leave that up to you if you want to respond to that. I didn't have a number.
I think in the syllabus it says a certain number.
I thought we had a minimum of 5. I'll go back and look.
Yeah.
And we'll follow up with the group on that for sure. Good question.
Yeah.
Professor Starnett, could you share that document? Because when I look at the generic document, it just tells me it should have references, it should have an introduction, a body, but it doesn't tell me how many words or pages you're looking for, because somebody could put 2 pages or 10 or 30 pages.
Shalini, if you go into I believe it's module 8, there is a document, a 1-pager that talks about what your paper should be 5 to 7 pages. Your PowerPoint should be an executive summary. And we talked about that in one of the Zoom calls. We said, 1 or 2 slides, because remember, you only got 5 minutes. And then there's it's really a rubric for the percentage of points for the different projects, and then the structure of the documents. If you can't find that, Shalini, in module 8, just reach out and we'll make sure we get it to you directly.
Sure. Thank you very much, Dr. Marion.
Great. Good. What other questions do you guys have?
Hi, Professor. This is Pamela Chike. For the executive summary, do we have to have references? I
think the references are part of remember, the summary is just to reflect. Did you want to say? Go ahead, Kate.
Oh, no, I was just going to say that. No, we'll be looking for that within your written document.
Okay.
There's no need to go into or have a separate slide regarding your references for the executive summary.
Okay, thank you.
Yeah, it's the executive summary, just so you guys don't stress about that. Really, just take the key points of your paper and just put them into a structured format and just walk the group through it, because we want to learn about what you learned, and you've got 5 minutes. And that's, I think, the goal of the executive summary is really to help you have an experience where you have to take a lot of information and compile it concisely and communicate it in a way that people can consume. So, Jennifer, you got a question? You raised your hand.
Yes, I have a question. Whenever we are in the listening group, after we've done our presentation, because I'm in the first group with your group, when we're in the listening group, do we just get credit for being there, or do we need to make sure that we ask at least one question? I mean, I didn't see a requirement about that, and that may be a silly question, but I want to make sure that I do what I need to do to get credit.
Yeah.
For being on the call.
Yeah, I look at it. I'm not going to be checking boxes if you ask a question, but I think I think it's the right thing to do to support your peers when they've spent a lot of time preparing, and so I would hope that people would just be actively engaged.
Well, I've noticed that we are very actively engaged group, and we do ask lots of questions, and so I just want to make sure if I can't get my hand up fast enough to ask a question, that I will still be counted, that whoever doesn't have the opportunity.
Yeah.
Because there's so many bright minds in here, and we just have lots of questions. So
absolutely.
Which is why we're splitting the group.
That's probably a great idea.
I love that. Yeah, that's really great.
Thank you very much.
Yeah.
Thank you.
That's great. All right, it's 7:01, and we'll have time for one more question if there is one. If not, I'm hitting the stop share button for sure, and then I'm going to find that end button and gone. You guys are great. We have a great class. I was so excited to be with everyone tonight, and also hear Dana's excellent talk. And I hope you guys found this not to be a waste of time.
It was very enjoyable. Thank you, Doctor.
Have a great Thanksgiving.
Good night.
Take care, everyone.
Good night.
Good night now.